Is racial profiling more benign in medicine than law enforcement? By David Wasserman. Number 1. Introduction. It might seem that racial profiling by doctors raised few of the same concerns as racial profiling by police, immigration, or airport security. I will suggest that the similarities are greater than they first appear. The use of racial generalization by police is more obviously threatening to racial minorities than their use by doctors. But the careless use of racial generalization by doctors can be equally lethal. Likewise, although the potential for insult is more obvious in policing than in medicine, the inappropriate use of racial generalizations is in one respect more problematic in medicine. It offends, or appears to offend, an ideal of individualized treatment that is more applicable to doctors than to police. Yet that ideal is poorly defined, and on any plausible definition, it does not categorically bar the use of statistical generalizations. The use of race or ethnicity-based generalizations may be permissible or even required in many medical contexts, but it is fraught with the danger of stigma-driven over-reliance. This tension, I believe, has no counterpart in law enforcement. 1.1. Racial profiling by police and doctors. Racial profiling, defined broadly enough to apply to an airport security line or a doctor's office, refers to the use of generalizations based on race or ethnicity to guide actions directed towards the object of those generalizations. By based on, I mean generalizations that take the form of individuals, or some subset of individuals, of group X are more or less likely than members of some index population to have, or do, Y. The scope of these generalizations can be wider or narrower, individuals of group X, or males of group X between the age of 16 and 24. Most generalizations used by the police have fairly narrow scope. When the Chief Constable of the British Transport Police declared, in the wake of the London subway bombing, that we should not waste time searching for old white ladies, he probably did not mean to suggest that they would be spending much more time on old non-white ladies, although members of either subgroup could conceivably have been recruited by a resourceful terrorist. I will use the term racial profiling to refer to profiling by ethnicity, nationality, and ancestry as well, since the differences between these types of classifications are notoriously unclear, and many of the most controversial instances of law enforcement profiling, for example, of Middle Eastern men in airport security lines, do not involve race in any contemporary use of that term. Consider then two cases in the same geographical setting, southern Arizona, that involve the use of generalizations based on perceived ethnicity. A man walks into a store where he is observed by a police officer, or he walks into a health clinic where he is observed by a doctor. In both cases, he is short, brown-skinned, and poorly dressed, speaking Mexican Spanish and no English. The police officer observes that he seems nervous in her presence and avoids eye contact. The doctor observes that he is coughing and congested with a slight fever. The policeman asks to see his identification. The doctor asks him to take a test for swine flu. Both the police officer and the doctor rely on a generalization based on ethnicity concerning the greater than average likelihood that an individual who appears to be Mexican will be, respectively, an illegal immigrant or a swine flu victim, given the locale and certain other factors. Some of those other factors will be more relevant to one professional than the other. The man's nervous demeanor matters more to the police officer. His cough and fever matter more to the doctor. but his apparent ethnicity makes a difference to both. If he looked Nordic, the police officer would have been less likely to request the identification, and the doctor would have been less likely to test for swine flu, at least before checking on symptoms that might rule it out, or suggest a different condition. The differences between the two cases may well seem more obvious and significant than the similarities. Although both generalizations are based on ethnicity, they are employed to support very different inferences. To illegal behavior and lack of citizenship in one case, to a contagious disease in the other. Moreover, the validation of the inference will have very different consequences. The police officer will detain the man for deportation. The doctor will write him a prescription and instruct him to stay in bed. The doctor can plausibly claim to use her generalizations for the man's benefit, a claim the police officer cannot make. But a few variations in the two cases suggest that the differences are not as great as they first appear, and that the doctor's use of an ethnic generalization may not be quite so innocuous. First, there are some circumstances in which the consequences of a medical generalization may not be so benign, because the doctor is not making the inference strictly for the patient's benefit. The doctor may be a public health official at a border crossing, charged with the detecting and denying entry to individuals with excludable conditions, or she may be required to report all suspected cases of swine flu not only to public health, but immigration authorities. For all I know, Arizona AB 1070 has such provisions. But these are cases in which the doctor is not acting in, or is legally required to depart from, her professional role as a healer to individual patients. I'll be more interested in cases in which racial or other group-based generalizations lead her to perform that role less effectively or appropriately, to make clinical errors, or to treat a patient in ways that could be seen as disrespectful. The former concern about the effectiveness is easier to illustrate. If the Arizona doctor is working a minute clinic, she may be pressured to make a quick diagnosis and prescription. The combination of the patient's appearance and symptoms may, in a way similar to readers of Groupman, cause her to overlook other conditions more probable than swine flu. Watching the clock in the grip of a stereotype, she may fail to inquire about other symptoms or perform other tests that would reveal the presence of an equally likely but more serious condition, with harmful or even fatal consequences to the patient. The concern about disrespect is no less important, but perhaps less obvious. It may already be present in the last case, where the doctor makes a mistaken diagnosis on the basis of an ethnic stereotype. It is insulting to treat a patient merely as a member of a racial or ethnic group, especially a group subject to widespread prejudice. Like the injury, the insult may appear to result from a failure to treat the patient as an individual. Whether the stereotype guiding the doctor's actions is negative or neutral, and even if it is solidly evidence-based, it may distract her from the individual standing before him. As Groupman states, statistics cannot substitute for the human being before you. Statistics embody averages, not individuals. 1.2. Treating patients as individuals. But what does it mean to treat a patient as an individual? It could hardly preclude reliance on statistical generalizations in diagnosing or treating the patient. That restriction would reduce medical practice to a guessing game, in which doctors would be barred from using their vast storehouse of largely valid generalizations. But if doctors must use generalizations, what makes some generalizations or some uses objectionable? One suggestion comes from Casper Lippert Rasmussen, who proposes that treating someone as an individual is a matter of taking into account all reliable, relevant information about him, statistical and non-statistical. So understood, the individualized treatment demands epistemic exhaustiveness, and it clearly does not preclude preclude the use of statistical generalizations. On this view, statistical discrimination is not found in the mere use of statistical generalizations, but rather may be found in their selective or inconsistent use. For example, in the use of more detailed statistical information about one group than others. Indeed, one can discriminate against a group by applying more refined generalizations to its members than to members of other groups. For example, a bank would discriminate if it used only income-based statistical generalizations about loan repayments for other applicants, but took account of wealth and education for black applicants to their disadvantage. Those applicants would receive more individualized treatment, but could complain of statistical discrimination. In contrast, I will employ a notion of individualized treatment that stresses epistemic openness rather than exhaustiveness. To treat someone as an individual in this sense is to treat him as a potential exception to any prejudice or diagnostic generalization that applies to him. It is to work under the assumption that one may discover additional information that distinguishes this individual from others in the reference group to which he has been assigned. That additional information may well be subsumable under a yet more refined generalization, but any such generalization will in turn be subject to further qualification. No generalization, however refined, will be exhaustive. This understanding differs from the Lippitt-Rasmussen's mainly in emphasis. A doctor who ignored or failed to obtain reasonably available relevant information about his patient would not treat him as an individual under either account. But a doctor whose treatment of the patient was informed by all such information through satisfying Lippitt-Rasmussen's conditions for treating him as an individual might not satisfy mine. He would fail to do so if he did not continue looking for, or hold himself open to finding, additional information that distinguishes this patient. Treating the patient as an individual in my sense not only requires being informed by all reasonably available relevant information, but taking a reserved or skeptical stance towards that information, regarding it as subject to correction or qualification. But perhaps that is part of what it means to be appropriately informed by such information. If so, the two accounts would not differ in substance. Both accounts also escape the criticism that demand for individualized treatment in medical practice is confused or quixotic. Malcolm Parker, for example, argues that the very idea of individualized medicine is confused if it is understood as involving anything more than that detection in an individual patient of features whose clinical relevance must in theory be subject to generalization. Purely individual characteristics, not anchored in some wider pattern, cannot be action guiding. Rather, what good clinical judgments require is attentiveness to potential generalizable variables and interactions. A doctor who sets aside an evidence-based generalization based on a hunch about a patient may be perceiving some feature of that patient that invalidates that generalization, a feature that ultimately can be incorporated into a more refined generalization. As I will use the notion individualized treatment, then it requires nothing more personal than sensitivity to such generalization qualifying features, and a commitment to detecting them. Understood this way, treating the patient as an individual is less a requirement than a regulative ideal for medical practice. Even if the patient can never be more than a set of symptoms for the doctor, she will do better job of discerning relevant symptoms if she sees the patient as potentially unique, as someone who may possess medically relevant characteristics that distinguish him from any other patient. A doctor who sees her patient this way must be ready to qualify or reject any generalization that initially appears to apply to him. There are obvious differences between treating a patient as an individual in this sense and treating a friend or lover as an individual. The doctor treats the patient as a unique organism or biological entity, not as a unique person, and she treats him this way for instrumental reasons. The better to discern other clinically relevant features. The extent to which friendship or love can depend on specific features of the friend or lover is a much debated issue in the recent moral philosophy, but even if there is a greater dependence on than some of us would like to believe, we're still committed to seeing the friend or lover as more than the sum or product of his observed characteristics. This commitment is part of what it means to be a friend or lover. It is not, as it is for the doctor and the patient, a mere heuristic to identify further distinguishing characteristics. True, we may be more likely to discover such characteristics if we do regard our friend or lover as more than the sum of his known characteristics, but this is not the point of so regarding him. For the doctor and the patient, that is the point. Even in its instrumental form, this is not an ideal that we would expect a police officer or a Transportation Safety Administration (TSA) employee to take to people she is monitoring. We certainly do not want the traffic cop or airport screener to take the time and effort to get to know us as unique individuals. Of course, we want them to keep their eyes and ears open for clues that an individual passing before them is not what he appears to be. A sensitivity to anomaly or incongruity may be a valuable trait in security personnel. We want law enforcement officers to be alert to the possibility of generalization qualifying features, but we do not want them to search relentlessly for such features. When doctors or police officers fail to be alert for anomaly or incongruity, they can cause or allow considerable damage. Obviously, the comparative damage from false positives and false negatives varies widely across medical and law enforcement contexts, but failures that result merely from indolence, complacency, boredom, distraction, or time pressure may injure the patient or citizen without insulting him. 1.3 Generalization and stigmatization. In medicine, as in law enforcement, the injury becomes an insult when the failure to detect differentiating features is attributable in whole or in part to stigmatization. We do not want a single characteristic, our race, ethnicity, sex, sexual orientation, disability, or age, to dominate all others, to obscure all of the other features that may be relevant to our health or security status. As Irving Goffman suggested in his classic work on the subject, the heart of stigmatization is the elevation of a single characteristic to a master status. So although we recognize, or should recognize, that our race or ancestry may be relevant to our medical diagnoses, we don't want the doctor to see us merely as a black, or a Jew, or even a middle-aged, middle-class black or Jew, and to focus on diseases or drugs she sees typically as black or Jewish. But this concern about stigmatization is not necessarily a concern about the failure to treat us as individuals. Although we want the doctor to look for characteristics that distinguish us from other members of our minority group, we also want her to attend to statistical information that is relevant to our diagnosis, but may be obscured by a preoccupation with our minority status. One way in which stigmatization can obscure important statistical information is by reinforcing the representativeness heuristic, the well-documented tendency to rely too much on the perceived fit of a symptom with a group stereotype, and the resulting failure to take account of baseline probabilities. For example, a doctor examining a black patient who complains of nausea, dizziness, and fever may be particularly prone to overestimate the probability that the patient has sickle cell anemia, a typically black disease, and to underestimate the probability of more common but less representative health conditions consistent with those symptoms. Of course, patients from less stigmatized groups may also suffer from the doctor's over-reliance on the fit of a symptom with a group stereotype. The doctor may see certain symptoms as representative of a typically white or white-collar disease, giving insufficient attention to less representative conditions with higher baseline odds. But she may be far more likely to engage in such stereotypical reasoning with patients from more stigmatized groups. Indeed, one study found that subjects took no account of base rates in estimating the probability that a West Indian individual was a burglar, while taking some account of base rates in estimating the probability for a white individual. Any injury that may result from such a wholesale neglect of base rates is also insulting, because it reflects the influence of stigma on professional judgment. We have similar concerns about a reliance on stigma-driven generalizations by law enforcement personnel. Although we certainly do not want TSA screeners to take the time to get to know boarding passengers as individuals, we do not want them fixated on stereotypical features, for example, on the Middle Eastern appearance, or Muslim attire of young male passengers, to the neglect of other features and other passengers who may present a greater risk. It may of course be impossible for a black patient or a Muslim traveler to know whether he has been subject to different treatment because of stigma-driven or merely ordinary over-reliance on representative features, but it may be reasonable for him to assume the former. 1.4 Race-based medical generalizations and individualized treatment. Although the use of racial generalizations in medicine has the potential for injury and insult, there is a strong trend in contemporary medical practice toward a reliance on race in diagnosis and treatment. In the past 2 decades, we've become increasingly aware of large health disparities between majority and minority populations. Disparities have resulted in part from the neglect of minority health. Like women, racial and ethnic minorities have often been excluded from or underrepresented in biomedical research. Differences in their disease susceptibilities and drug responses, whether due to genetic, environmental, or socio-cultural differences, have until recently received relatively little attention. The challenge is to overcome this neglect without falling prey to the opposing tendency to give race too much weight. Consider a black patient who presents with a collection of symptoms consistent with several underlying conditions, for which the treatment would be very different. Some of these conditions are more common in some socially defined racial groups than others. It seems reasonable for the doctor to test for the most likely conditions first. As Tishkoff and Kidd observe, many different disorders have similar symptoms, and the process of differential diagnosis can use ethnicity to prioritize testing according to the most likely etiology. Whether genetic, infectious, or environmental, the causes of the disorders vary among ethnic groups. Economics and common sense argue that one would attempt to confirm or reject the most likely cause before attempting to confirm a very remote etiology. Taking ethnicity, genetic ancestry, and sociocultural characterization into account can be good medical practice. It thus seems clear that in some cases, the patient's race should play a role in which tests the doctor should order first. It also seems clear that a doctor may give too much weight to race in setting the order. As suggested earlier, a general tendency to ignore base rates may be reinforced by the salience and power of racial stereotypes. Or consider a patient with a known diagnosis and a doctor with a choice of Federal Drug Administration approved drugs equally effective in the general population. If the patient is black and several recent studies have found the drug to be more effective in blacks or have fewer side effects, it seems reasonable for the doctor to start with that drug. But it is also likely that the doctor will give the patient's race too much weight. Her decision to prescribe a black drug for a black patient may rely on a racial stereotyping more than statistical information. She may be too quick to make that prescription or too slow to change it in the face of poor results. Tishkoff and Kidd recognize these concerns in warnings that in taking account of race and ethnicity, the doctor must be wary of racial profiling and ignorance of the continuous nature of genetic variation and high levels of admixture in modern populations, which can result in misclassification and misdiagnoses. But it is not clear how even the most conscientious doctor can bring these caveats to bear in deciding which conditions to test for first, or which medications to start prescribing. Another concern frequently raised by the reintroduction of race into clinical medicine is that it will help revive the largely discredited idea that race is a well-defined biological category. That idea, reinforced by a simplistic biological determinism, has contributed to the invidious racial stereotypes that we are only now slowly and painfully discarding. But its rejection does not preclude a social stereotyping that may be almost as harmful, if less invidious in a medical setting. The belief that race is a central social category, reinforced by a naive social determinism, can encourage the uncritical and misleading application of social generalizations. Thus, a doctor may assume that people of the same race will have very similar social backgrounds and experience, yet an individual, black patient, may possess few of the social factors found disproportionately among blacks. He may have been raised in a prosperous, stable, and nurturing family in a friendly environment with little experience of hostility, exclusion, or subtler forms of prejudice. In uncritically applying a racial generalization bearing on the patient's health, the potential harm may be much the same whether the doctor assumes that the generalization applies because of biological or social factors. Her misdiagnosis or misprescription will be no less damaging in the latter case than the former. This is also true to some extent of the offenses to the patient. The insult may be no greater if the doctor assumes the patient has behaved or will behave like other members of his race because of social rather than biological similarities. As I have argued elsewhere, it shows a lack of respect to the autonomy of an individual to infer his morally significant behavior from the average behavior of a reference group to which he belongs. The offense can be as great for reference groups defined socially as biologically. What matters is the nature of the behavior inferred. The more immoral or illegal the behavior, the more objectionable a race-based inference. The inference that a poor, young, urban black uses crack is far more troublesome than the inference that a poor, young, rural black eats a high-fat diet, more a matter of exposure than behavior, although the latter inference may be as unwarranted and dispensable as the former. In many cases, the doctor may be ignorant or agnostic about the reasons that a condition is more prevalent in one race, or that a drug works better for patients of one race. But if it turns out that the major factor accounting for the racial difference is behavioral, for example, the less healthy diet or high smoking rate of blacks, the doctor will in effect, but not intent, have applied a negative behavioral generalization to his patient. Of course, the basis for prescribing a race-specific drug or a test is not always so innocent. It may be widely assumed that a particular cause is responsible for the correlation and may, partly as a result of that casual assumption, overestimate the strength of the correlation. Once a causal explanation is established or assumed, The process of making individual exceptions may be awkward. A black patient may be asked to take a genetic test or to give a social history not requested of white patients. He may see it as being asked to prove that he does not fit stereotype, an exercise that may be painful because of his association with efforts to exclude himself from more invidious stereotypes. If the test or inquiry would take time that the physician cannot spare or impose costs that the patient cannot pay, the doctor may end up relying on the generalization. Indeed, such reliance might be best for the patient if the cost of making exceptions is high, and the harm from a mistaken assumption minor. But this recourse to racial generalization would still be troubling. 1.5. From race-based to genomic medicine. Many people hope that genomic medicine will make it possible to get beyond race. The expectation is that the doctor will be less likely to treat the patient merely as a representative of a racial group, and more likely to treat him as an individual, if she treats him as the bearer of a unique genome. This is certainly not what Groupman had in mind in urging doctors to see their patient as individuals. He sympathetically relates the complaint of an eminent hematologist that doctors have become so wedded to genetic profiles that they ignore the individual characteristics of the patient. Even if the profile included the whole genome, it would be static, and even if it included gene-to-gene interactions, it could not incorporate the patient's history, the environmental circumstances, and events that interact with his genome and individuate him still further. As Smart et al. Note, genetic profiling will not make medicine truly personalized, but it will rather place individuals into increasingly refined reference groups. If treating the patient as an individual is seen as a regulative ideal, however, the use of genetic information can be seen as a step toward that ideal. It moves the doctor from a one-size-fits-all diagnosis or prescription to one that takes into account many, though hardly all, of the patient's differentiating characteristics. But genomic medicine may also have countervailing tendencies. In making some of the patient's distinguishing features more salient, it may obscure others. As Groupman's colleague worries, doctors may become so wedded to genetic profiles that they will neglect more personal details about the patient, his history, appearance, and description of his own symptoms. That may be as or more valuable for differential diagnosis. Another danger is that genomic medicine will, at least initially, increase rather than reduce clinical reliance on racial classification. At present, race is a useful and even indispensable proxy for some genetic differences. As human geneticists and physical anthropologists stress, however, it is a very rough proxy, because genetic differences arising from geographical ancestry have been greatly attenuated by the racial admixture of almost all modern societies. This rough fit increases the dangers discussed above of over-reliance on race-based medical generalizations. Finally, individualized genomics cannot completely bypass the use of race in clinical medicine. As noted above, race is useful for differential diagnosis or treatment, not only because of genetic differences that will someday be identifiable without recourse to race, but because of environmental or behavioral differences that reflect the continuing use of race as a social category. 2. Conclusion. The return to the Arizona case, the swine flu testing of the Mexican patient based in part on his ethnicity would not be problematic if it was informed by the best available information about the probability that his symptoms arose from swine flu, and if it was done as a confidential medical procedure with the patient's consent and with no tie to immigration enforcement. Such testing would not be based on the assumption about the patient's behavior and would have no adverse consequences. If the doctor was likely to focus on swine flu to the exclusion of other, more probable or more serious conditions, she should perhaps defer testing to ensure the more careful exploration of those alternative possibilities. But she cannot and should not try to ignore the patient's ethnicity in diagnosing and treating him. In contrast to law enforcement, which should rely as little as possible on racial and ethnic classifications, contemporary medicine cannot ignore them. Race and ethnicity are associated with the geography of disease, with social and cultural factors relevant to disease, and to some extent with genetic predispositions to disease. Moreover, the greater attention to the distant relative susceptibilities of certain racial and ethnic groups is necessary to make up for past neglect, but it will be a tricky business to steer a middle course between naive, reckless, or dogmatic colorblindness and a stereotype-driven over-reliance on race and ethnicity. In trying to steer such a course, the doctor can only hope for a day when a combination of more individualized genomic medicine and greater social equality will make it possible for her to pay less attention to race and ethnicity without detriment to her patient's health.